Yeah. So it's, as Monica already pointed out, it's protracted bacterial bronchitis is my topic here. I do not have any conflicts of interest regarding to this one. And actually, I'd like to start off with a question. A 2-year-old boy presents with his first episode of wet cough that has started 6 weeks ago during an upper respiratory tract infection. It has persisted since then. The past medical history is insignificant. Growth and development were normal so far. The boy is well, afebrile, with a wet cough and a clear chest on auscultation. What is the best initial treatment? Inhale bronchodilator for 1 to 2 weeks, inhale corticosteroid for 2 weeks, oral antibiotic for 2 weeks, oral antitussive for 1 to 2 weeks, or oral corticosteroid for 5 days. Please select your choice. Okay, that is good. So I do not have to cover all the details in this short talk then, because 83% of you opted for the correct answer, which is antibiotic for 2 weeks. Okay, I have to close, I think. Yeah. Sorry, I can't handle the slides. Yeah, okay. So oral antibiotic for 2 weeks. And these are the aims, they're quite obvious. I skipped this slide. If we talk about PBB, I use PBB now because it's such a long term. We have to talk about chronic cough. And there are different, actually, when you look at different papers and when you look at adult literature or pediatric literature, there are different definitions of chronic cough. So if you go back to this very old European Respiratory Journal paper, which was an ERS task force. This was mainly covering adults, only a little bit pediatric stuff. They talked about chronic cough, a cough to last more than 8 weeks. And a little bit later, and this is now very common in the pediatric population, you would call a chronic cough when there is daily cough for more than 4 weeks. And there has been a recent publication, these ERS guidelines on the diagnosis and treatment of chronic cough, both in adults and in children. And when you look at the flow chart here, then you see a few, this is only the very beginning of a very long flow chart for the pediatric population. You see a few very important things, which is a detailed history, which is a physical examination, obviously, symptoms and signs suggestive of specific disease. Then the main investigations here, but what I want to point out here is mostly that specific pointers are not identified. And then you differentiate between wet and dry cough. What is these specific pointers? They're very important in this context. These can be symptoms, signs, and also test results. Symptoms like chest pain, like dyspnea, like hemoptysis and others. Failure to thrive, for instance, as well. Signs like respiratory distress, digital cupping, deformities, and also pathological radiology, apart from very mild perihilar changes or abnormalities in lung function. And this is taken actually from the ERS statement on PBB published a few years ago. So specific cough pointers, they must be absent when you talk about PBB. When you go back to history of PBB, there are several definitions as well. The first definition was this one, what is now called PBB micro. This was first described in Brisbane and was microbiology based. So it was the chronic wet cough for more than 4 weeks, as we said before. It was slower airway bacterial infection, so more than 10 to the 4th colony forming units per mil, and resolution of cough within 2 weeks of an appropriate oral antibiotic. So PBB micro, the original definition. The modified definition is a clinical-based definition. Again, it's the chronic wet cough for more than 4 weeks. Again, it's the resolution of cough within 2 weeks of an appropriate oral antibiotic. But it's not the microbiology here, but the absence of symptoms or signs, the so-called specific cough pointers of other causes of wet or productive cough. So this list is really important here. This slide changed somehow. So the oral antibiotic is usually amoxicillin clavulanate, and only in a minority of children, 4 weeks of antibiotics are required. I'll come back to that. This is a review from a review paper, again showing you the PBB micro, I told you that, the PBB clinical, and also the PBB extended. This is micro or clinical, but the cough only resolving after prolonged periods of time, like 4 weeks of antibiotics. There has been everything recommended in the literature from 2 weeks, 4 weeks, up to 5 or 6 weeks even. Recurrent PBB is recurrent episodes, more than 3 per year of PBB as per definition. What about epidemiology? The true prevalence in the disease burden with the communities is widely unknown. There are mainly studies from Australia, but also Turkey, both single and multi-center studies, showing that PBB it's very common in those children that are referred to a specialist respiratory clinic. One of the most common causes of cough, of chronic cough, obviously. So in this series, it was like 10 to 40% of children. Very often misdiagnosed as asthma, and all these children had many doctor visits and also impaired quality of life. So very important for the children and the families here. What about pathophysiology? In many of those, and this has been shown in the 3 studies shown at the bottom of this slide and in others as well, there is an association with airway malacia, so tracheomalacia, bronchomalacia, or a combination of tracheo-bronchomalacia. But as yet, it's not clear whether airway malacia is just a predisposing anomaly or a consequence maybe of this PBB, or just a coincidental finding. This is a retrospective review, and you see that 3/4 of patients who fulfilled the criteria for PBB micro at the time, so with the microbiology part of the definition here, also had either bronchomalacia or tracheomalacia or both. And this has also been shown by other studies that were prospective in nature. So a very strong association, but still unclear what's the hen, what's the egg here. In terms of microbiology and inflammation, what you usually find in these children is either non-typable Haemophilus influenzae, strep pneumoniae, or Moraxella catarrhalis. And in many cases, up to half of the children, you will find multiple bacterial pathogens. If you find Pseudomonas aeruginosa, you should consider other diagnoses. So it's not so common that you find Pseudomonas. I'll show you a graph in a minute. Sometimes also viruses are co-present, like adenovirus, but also CMV and EBV have been described recently. There's obviously neutrophilic inflammation, but again, different to other diseases. This is a paper, quite recent paper, that compared PBB children with bronchiectasis children. So this is the light gray PBB, the dark gray is bronchiectasis, and the black is CF. And you can see that the PBB and the bronchiectasis children are quite similar in terms of bugs. So again, Haemophilus, strep pneumoniae, Moraxella. And these are not so common in CF. In CF, more common, as we all know, is Staph aureus, Pseudomonas. And these are less common in PBB and bronchiectasis. When you look at the inflammation part, then you again see similarities between PBB and PE, and you see it's quite a large number, quite large numbers of children. You see there is neutrophilia, but not as pronounced as it is, for instance, in CF. Clinical features. It's typically young children. Most of them are preschoolers, but has also been described in adolescents. And very typically, the children appear well. They do not have any systemic symptoms. They do not have evidence of sinus or ear disease, no signs of chronic suppurative lung disease, and normal growth and development. Occasionally, there's a rattly chest and crackles, but very often auscultation is unremarkable. And again, the chest radiograph is normal or near normal, apart from slight peribronchial changes. If you do lung function, if you can perform lung function in these children, spirometry is normal in these children as well. So this is again taken from the ERS statement on PBB. You have got this chronic cough here. It's wet or productive, absence of specific cough pointers, and then you should try to attempt a sputum culture and then do a trial treatment for PBB. What's this trial treatment like? As I said, it's usually 2 weeks of an oral antibiotic. The choice of the antibiotic is frequently empirical, certainly determined by local patterns of susceptibility. Most widely used antibiotic is amoxicillin clavulanate. There are alternatives like cephalosporins or macrolides. The role of azithromycin as a kind of a longer lasting treatment in PBBs is undefined. And the same is true for airway clearance techniques. They're not universally recommended, but in children with tracheobronchomalacia, and these are many of the children, probably these techniques have their place. Again, azithromycin, the answer in pediatric respiratory medicine, but what was the question? A nice paper to read. What about outcome? This is from Stoke-on-Trent, a UK study. You see 44 children with PBB. 3/4 of them had, after the first treatment course, had a complete resolution and 10 incomplete resolution. But you see, if you go further down, then they behave differently. Some with no relapse, some with 1 or 2 relapses, or even more. And some of them even had to be started on prophylactic antibiotics or treated or investigated for other conditions. So quite a mixed outcome. The majority of children, however, respond very well to antibiotics, and usually reasons for treatment failure are either non-adherence or there's underlying causes, other underlying causes that were not thought of before, so further evaluation is needed in these children. There is, however, a subgroup, or there are subgroups with recurrence disease, as I told you, and development of bronchiectasis. And in the Brisbane cohort, this is 44% with recurrence disease and 8% of children developing bronchiectasis. And what has been published from the Brisbane group is that the risk factors for development of bronchiectasis is recurrent PBB, but also infection, chronic infection with Haemophilus influenzae. So there is, and this is the last slide already, so I'm perfectly in time this time. There appears to be a spectrum with all these entities I mentioned here, ranging on the one extreme end from PBB micro or PBB clinical over PBB extended, recurrent, with an overlap with chronic suppurative lung disease, and again with an overlap to radiologically proven bronchiectasis. Reversible in the first instance, as we know. This is in contrast to what has been told before, that bronchiectasis is always irreversible. There is clear indications that there are reversible forms. So there appears to be a spectrum, and this makes also sense in terms of the pathobiology when you look at the different entities here. Thank you for your attention.
Well, thank you very much, Ernst, for this presentation. And I have a few questions for you, or actually none so far. Sputum is difficult to obtain in young children. Can you use a cough swab instead?
So, I mean, of course you can try to use a cough swab, but if the cough swab is negative, it will not tell you the story, because usually what is when it comes to the definition, this was BAL specimens. So at the very beginning, all those authors talked about BL fluid and then the positive culture with at least 10 to the 4th of CFUs. Sputum induction might be a way to come around that.
Yeah.
At least in our experience here, we hardly do any swabs anymore in CF children. So from infancy, we go on with induced sputum, and it works very well, with at least a 90% success rate to get proper induced sputum.
And to follow this up, can you briefly describe how you obtain induced sputum in a young child and an infant? Yeah,
we do inhalation with hypertonic saline with 6 or 7%, and usually it's the chest physiotherapists that do that in our center, and then they have their tricks to get the child coughing, and then they do suctioning from just above the larynx, suctioning of secretion that is coughed up to the larynx.
So it's almost like a cough swab, just suctioning the secretion.
Did you say cough swab before? Then I misunderstood you maybe. I'm sorry. I understood throat swab, so sorry.
Yeah, okay. Yeah, so coughing and then swab and induced coughing.
Yeah.
Okay. So this answers one of the questions. There's another question, when or is bronchoscopy indicated in recommended in a child who doesn't respond to the antibiotic treatment if you suspect PBB or have diagnosed PBB?
Yeah, certainly, because chronic cough, unexplained chronic cough is a very key indication for doing bronchoscopy.
And what would you recommend then?
And of course, bronchoalveolar lavage.
Yeah, okay. At the moment, I cannot see any more questions for the PBB, but there may be some more questions for Marielle. Marielle, are you still there?
Yes, sure. I tried to answer some questions in the chat already.
Yes, I've seen that you've answered quite a few, and some might be interesting for everybody. You can read those up. I have seen one question which you didn't answer. Is there a clear difference between small, medium, and large effusion, and how do you estimate from the size of the effusion?
I did also, because it's a difficult question. But in general, the small effusions are less than 1 centimeter on the chest X-ray or on the ultrasound, or less than a quarter of the chest. Yeah, then you get what's large. Well, large is 2-3 centimeters on the ultrasound, I would say, but I don't think there's a very clear cutoff. And I would go for large if it's more than half of the chest that's filled with pleural fluid.
Okay.
But again, I think the most important is the clinical condition of the child. So if the child is in respiratory distress, yes or no. If it's ill appearing, yes or no. I think that's the most important reason why you should put in a chest drain, yes or no.
Mm-hmm. Okay. And some more questions for Ernst. And if you see a case with suspected PBB in the ER, so acute presentation, do you consider collecting sputum as mandatory, or could you just prescribe antibiotics?
Yeah, I mean, usually you wouldn't see these children in the ER because they are not acutely ill. They're just coughing chronically, so they are well. So I wouldn't think that I see a child with PBB in the ER for this reason. I mean, but I mean, if so, there's no hurry actually, because the child, if it fulfills the criteria of PBB, the child must be well with a normal chest X-ray, with a normal lung function, with nothing really remarkable, and then you've got time. So I would, before I do any antibiotic treatment, I would go for a sputum culture. Yeah.
Okay.
If I really think of PBB.
Yeah. I could imagine a child who comes with an acute exacerbation or acute bronchitis, which you suspect might be viral induced. And when you take the history, the mother is telling the child has been coughing for 6 weeks. As a first line treatment, you still would recommend to do a culture before you start empirical antibiotics.
I mean, I mean, in theory, this would be the right way to go, but obviously that there would be one or the other situation where you would go for antibiotic treatment, and then you would, in my region, you would take amoxicillin clavulanate and then prescribe that for 2 weeks, and in case everything is fine thereafter, it's fine. If not, then you certainly would go into more detail, also in terms of investigations. But I would try to first get the culture.
Yeah. There's one interesting question. What is the difference between chronic cough and atopic cough?
Atopic cough?
Yeah. I would understand this question. You might have a child with a history of atopy and some suspected bronchial hyperreactivity who might present like a child with protected bacterial bronchitis. What do you do? I
mean, if you've got this child, this child is very unlikely to have a wet cough, because we were talking chronic cough, but we were talking chronic wet cough. So it has to fulfill the criteria of wet or productive cough. Yeah. And this I wouldn't expect that in a child with atopy and hyperresponsiveness.
So it really is a matter of exact history taking, whether it's a dry cough or a wet cough, and the best is to observe the child coughing.
Yeah. Yes.
So, and one more question for Marielle. If a child, now this is bilateral empyema in infants with mediastinal collection, how long to give antibiotics? Or when to investigate for immunodeficiency? I think this is an important part. When should you consider immunodeficiency?
Yeah. Well, if you have bilateral empyema in a very young child, you are not going to wait too long to give IV antibiotics the time to work. So you will intervene, I think, quite early. And when to investigate for immunodeficiencies. If you look at children with empyema, it's not specifically the infants with bilateral, but in children with empyema, only a very small minority has an underlying immune deficiency. And if this is the only episode of a severe infection, actually you don't have to look for immune deficiencies. But of course, if you have very complicated disease or children have more infections, I would go for a screen for immunodeficiencies, but not in the acute phase. So first, children have to recover before you can look at immunodeficiencies.
Yeah. And then one final question for Ernst. Is there an indication for CT in PBB?
Not in the clear-cut case. I mean, if a patient has recurrent PBB and develops, and you think the child might develop or might have developed already chronic suppurative lung disease, or even maybe bronchiectasis, then of course you have to do a CT to detect or rule out bronchiectasis. Mm-hmm. But I think this is only a place for children who are going far beyond, at least to recurrent PBB, and children who do not get well, so the wet cough continues even with prolonged periods of antibiotics. I mentioned before that there are several recommendations going up to 6 weeks of antibiotics, and actually there's one study, I can't recall the author or the journal, but that showing a slightly better outcome with even longer periods of antibiotic treatment, like 5 to 6 weeks as compared to 2 weeks. But this was a weak signal, and there is no clear information on that. Some of the children were reported to really need prophylactic antibiotics to kind of get that under control. And in these children, I would certainly go for additional investigations like a CT scan. Yeah.
And bronchoscopy. And there's one very last question. If you decide to do bronchoscopy in a child with PBB, how many days do you recommend without antibiotics in order to culture secretions successfully?
Difficult question. I mean, it also depends on how sick or how problematic the situation is. As long as possible, at least 2 weeks, I would say, as a rough guess. Mm-hmm. But this is just
and no data, right?
No data.
Mm-hmm. Okay. Well, thank you very much, both of you, Professor Pindenburg, Professor Eber. I think we have a well-earned lunch break now, and we'll meet again in an hour's time with case-based discussion on